Thank you everyone for joining us again for another exciting monthly academic global surgery meetings. And today's topic is entitled Patient Blood Management in No Middle Income Countries. And we are very blessed or happy to have two of incredible speakers to unpack the topic for us, Prof. Vernon, Louw, and Regan Boden. So I'm just going to give you how the flow of how the presentations will go. I'll introduce both speakers at once, and then after that, I will give it to Regan to give an introduction to the topic, and then after that, we will then give it to our main speaker, Prof. Louw, to just unpack it more fully, and then after that, I will provide 10 minutes for questions and answers, and then obviously for others, if you have burning questions or burning comments, you can just put it down on the chat box, and I'll keep checking and seeing what has been written there. So just without wasting time, I will introduce our speakers. I'll start first with our main speaker, Prof. Vernon Louw. Prof. Vernon Louw is the chair and head of the Division of Clinical Hematology in the Department of Medicine at the University of Cape Town since April 2018. He held previous roles as professor and head of the Department of Internal Medicine at the Faculty of Health Sciences at the University of the Free State in Bloemfontein since 2013, and head of Division of Clinical Hematology from 2004 to 2013. After completing his NB-CHB and NMed in Internal Medicine at the University of Stellenbosch University, both with summa cum laude. In 2011, he obtained his PhD in Health Professions Education at the University of the Free State on the development of a postgraduate training program in transfusion medicine. And in 2015, he received the National South African Registrar Association Award for Excellence in Teaching and Research Supervision. Most interestingly, his research focuses on iron-related disorders, both iron deficiency and transfusional iron overload, patient blood management, transfusion medicine education, hematological malignancies, and HIV-related hematological disease. Professor Louw has authored and co-authored more than 100 papers in peer-reviewed medical journals with more than 300 poster and oral presentations at local, national, and international meetings. Professor Louw is a member also of the several professional societies, including the American Society of Hematology, the Hematology Association, American Association for Blood Banking at the International Society for Blood Transfusion, and is a founding member of the South African Clinical Hematology Society. Very, very impressive. He also serves on the World Health Organization Strategic Committee for Patient Blood Management, the Global Transfusion Forum Steering Committee, Education Committee, Subcommittee, and the Global Standard Committee for Transfusion Medicine, and the International Collaborative for Transfusion Medicine Guidelines Committee. So we're really, really fortunate to have you. You're literally so qualified for this topic that we have today. And our second speaker, which is Regan. He's a final year medical student at UCT, obviously, and a member of Global Surgery Student Research Group. He has previously been a deputy president of UCT Surgical Society and is passionate about increasing access to high quality healthcare in South Africa. I would love to give it again a warm welcome to our speakers, and I will give it to Regan to introduce the topic, of which he will then hand it to Prof. Louw to give us an incredible main talk. Thank you. Regan, you can go ahead. Great.
Thank you so much for the intro, Caroline. Yes. And yeah, just to say, such a pleasure to have planned this with Prof. Louw. Yeah, obviously you can tell from his CV how qualified he is. Yeah. Can you see my screen?
Yes, it's perfectly clear. Yeah, perfect.
Okay. So today we're going to be talking about patient blood management. My role is to give a bit of an overview of the topic and the idea before Prof. Louw delves into some of the real nitty-gritty for us as health professionals in South Africa. So, we all are familiar with blood products and their use, and we all know how vital it is to give blood products to some of our patients, especially in surgical conditions. Blood loss is a huge thing that we deal with and meet with very, very often. However, blood products are not benign. They should be considered like any other drug, i.e. there's specific indications of when to use blood products. They should be prescribed carefully, and we should be very knowledgeable about their side effects and the management thereof. Additionally, blood products are expensive. Not just to, sorry, my screen's doing some funny things. Blood products are expensive, not just to give to patients, but to harvest, organize, separate, manage, and administer. And when you start talking about their side effects, that becomes even more prevalent. So the solution, right? We have this really important drug that we need to be able to give to the right patients that comes with side effects and problems. The solution is an idea called patient blood management. I've tried to bring a few different definitions from the literature together in a way that makes sense for our topic. But it's an evidence-based bundle of care that optimizes medical and surgical patient outcomes by clinically managing and preserving a patient's blood. This includes diagnosis, treatment, and follow-up of patients. It's very important, obviously, in surgical patients where PBM interventions or patient blood management interventions should start up to months preoperatively, continue during cutting time, and persist in the post-operative period. So this is just a quick slide that Prof. Louw will speak more about, but it's just a summary of some of the evidence behind how important correct use of patient blood can be in reducing mortality, hospital-acquired infections, and the cost of giving care to patients. So the pillars of patient blood management can be divided into three places: optimizing erythropoiesis, minimizing blood loss, and planning for and optimizing physiological reserve for anemia. And given our context in global surgery, we can think of all of these pillars in the preoperative, intraoperative, and postoperative phase. But in terms of optimizing erythropoiesis, it's really important to detect, flag, treat, and follow up patients with anemia, including those who are anemic but are very physiologically compensated. We have to consider common causes and risks for anemia in all patients preparing for surgery. We should be really seriously considering IV administration of iron, or even delay of elective surgery if possible, to defer using from blood products where relevant, and to really take a good history about medications that may suppress erythropoiesis. We also really need to be maintaining or minimizing blood loss. That includes identifying and managing the bleeding risk. This is important through history, exam, and investigations. Minimizing phlebotomy, minimizing normothermia, or maintaining normothermia, using hemostatic agents where appropriate, and monitoring our patients post-operatively for bleeding. Then we also have to do the last pillar, which is planning and optimizing patients' physiological reserve for anemia. So this includes identifying high-risk patient groups early on in the process, optimizing hemodynamics and oxygenation of patients, to avoid and treat infections promptly, and to use restrictive transfusion thresholds, which are really elaborated on the literature, and I'm sure Prof. Louw will speak about. So that's an overview of the topic. That is patient blood management, why it's important, and let's hear from Prof. Louw to really give us more about that.
Good afternoon, everybody. Can I just confirm that everybody can see my screen and hear me well?
Yes, we can.
Excellent. Great. Well, first, I just want to say, Caroline, thank you so much for that very kind introduction, and Regan for introducing the topic. It's so nice to work with people that are enthusiastic, that want to do great things. And I really enjoyed working with Regan before. But I have to also say, it sounds like I'm sort of doing all this work about patient blood management, which is absolutely not true. This is a truly collaborative team effort with many people all around South Africa and now beyond that's working together on this. And in Groote Schuur, I want to specifically just mention Matthew Gibbs and Christella Alphonsus in the Department of Anesthesiology that is really playing a leading role in all of this. So these are just my disclosures. Sometimes I do lectures and I'm compensated for that to pharmaceutical companies. The things at the bottom is hard work and no compensation, but just maybe worth mentioning as they impact on this topic. So, you know, one of the most difficult things when I give a talk like this is to decide what to mention and what not. And I'm always worried that there will be someone in the audience that I won't get the chance to speak to again. So typically I try to put in a whole lot of things that may be more than needed. So today I'm going to try and limit it to these main issues or main points. And then hopefully if there are people who are interested, we can always zoom in and do a few of these specifics in more detail at another occasion. But today will be more like a bird's eye view over the concept of patient blood management and our specific experience in South Africa, which I think is more or less reflective of a lower middle income country's experience from what I've seen. So a quick reminder about what patient blood management is. Let's start with a patient that you would like to take to surgery. You know, you see a patient, and in the perfect world, your patient's preoperative hemoglobin will be normal because it was optimized by somebody. We believe that somebody unnamed for now, preoperatively. Intra-op, you will not lose any blood, and if you do, you will salvage all of it and give it back. And post-operatively, no further blood will be lost and or at least salvaged if there is blood loss. Now, obviously, that's not the real world. In the real world, most patients arrive at surgery with suboptimal HBs. They lose blood, their HB decrease further, and post-operatively, it goes even lower. And the traditional paradigm has been to respond to each one of these phases by giving transfusion. I think in South Africa, we've been able to brag with probably some of the safest blood in the world, despite the HIV epidemic. The reality is that if we speak about blood as safe, we can say that it is as safe as blood can possibly be made by a blood service. And our blood is safe, especially from a point of view of infection, because all the best tests in the world are done on our blood to make sure that our patients or that our donors don't have HIV and hepatitis B, C, etc. The reality that we're now being confronted with is that blood transfusion is not as innocuous as we thought. And there's a lot of other things, blood being a liquid transplant that we did not realize before, and effects on one's immune system and many other organ systems that have a greater negative impact than was previously recognized, and things that the blood service can do nothing about. Now, it's estimated that surgeons use about 50% of the world's blood supply. And the question is, how can we turn this around? How can we change this traditional paradigm of giving what is supposedly safe transfusion and still optimize the patient's condition while we're doing surgery? And the way to do it is through what is called patient blood management. And patient blood management, in essence, rests on these three pillars. First, developed in surgery. The surgeons have really been the pioneers, but since it's now been rolled out in pediatrics, in internal medicine, obstetrics and gynecology, anesthesiology, everywhere. And the key pillars are optimizing the patient's red cell production prior to surgery in the surgical context that we're talking about today, minimizing bleeding and blood loss, and harnessing and optimizing the patient's physiologic tolerance of anemia, not just knee-jerking blood transfusion. So recently, very recently, a new global definition of patient blood management was published by a collaborative of all the major societies in the world. And it basically has a number of key elements. And I want you to see and distinguish this from blood conservation. It's a patient-centered, systematic, evidence-based approach to improve patient outcomes. That's very important. By managing and preserving a patient's own blood, all of us walk around with built-in blood factories. You know, if we can optimize our factories, we do not need to take from anybody else's factory through a blood donation. At the same time, we want to promote patient safety and empowerment. And this concept is thus not centered on a specific pathology, department, or procedure. It's not centered on a specific discipline or sector of medicine. And it is aimed at managing a resource, the patient's blood. And I want you to realize this as distinct from blood conservation and so-called transfusion medicine. You know, it's a very strange thing. We don't talk about antibiotic medicine, but we talk about transfusion medicine as if transfusion is at the center. No, we talk about the disease and the patient at the center. So here we're focusing not on conserving blood in the blood bank, but we're focusing on conserving and optimizing the patient's own blood. So the attention is shifted from what blood can I give to what blood do I have that I can optimize. So with that in mind, the World Health Organization got involved with this more than a decade ago already, but now has published some significant documents to ask for the urgent worldwide implementation of patient blood management. I'm fortunate to be part of the team that is developing the package to roll out for the actual implementation around the world, but I'm working with the most amazing people around on this, and it's just so exciting to see what is happening. So the principle is that your own blood is the best thing to have in your veins. And I think if I ask any of you, if you had to go for surgery, and or if one of your families had to go for surgery, would you prefer to have blood transfused during the surgery, or would you be happy to have everything else done not to have a transfusion? And I think that answer is obvious. If not, we can look at this study, which is the largest study ever done so far. There are many like this, but this is the biggest one. They included the whole of Western Australia, almost 700,000 patients, and they implemented the concept of patient blood management, focusing especially on optimizing patients' hemoglobin before they are operated on, especially in elective surgery, to rather delay the surgery and optimize the HP before taking the patient to theater, by learning and teaching minimum blood loss techniques, and by not giving unnecessary blood after surgery, but rather treating the cause of the anemia, which has mainly been iron deficiency or iron restriction. And what were they able to do? So what you can see at the back here in gray is that in Western Australia, during the course of this study, the population grew. But from when they started the program around 2008, 2009, the number of units of blood transfused to patients decreased by about a third. And they brought their transfusion rate down from about 31 per 1,000 population to about 21. Now you say, okay, that's great. That's probably a good cost saving. But here's the unexpected. And this is what Regan showed you in the beginning, and I want to just focus on a few things. Shockingly, the in-hospital mortality decreased by 28%, hospital-acquired infections by 31%, heart attacks, by 21%, heart attacks and strokes by 31%, hospital stay by 15%, and all-cause emergency readmission was the only thing that went up slightly by 6%. Pre-op anemia was not very high in their case, 21%, but that came down to 14%. You'll see what it looks like in South Africa soon. Single unit transfusions, which is a key part of patient blood management, which means that in the modern way of treating patients, unless you have activated a massive hemorrhage protocol, and unless you're resuscitating a patient with blood, you're not supposed to order more than 1 unit at a time. So you can see here that they were able in 5 years to increase their single unit transfusions from 33 to 64%. They saved on number of red cells, plasma, and platelets transfused, and in total saved about 100 million South African rands on blood product costs directly, and almost 1 billion rands on all the activity-based costs. So you've got 1 billion rands saved, more than 1 billion, and improved parameters of outcome. So it will not be a shock to you that patient blood management has already been accepted as a resolution by the WHO in 2010. It's become law in places like Italy. It's a quality measure as part of NICE in the UK. And almost every European country has now got patient blood management guidelines and standards. And in South Africa, we are also working on our own. So why are we doing this? What is the landscape looking like in South Africa? So in 2018, we had about 57 million people. We'll know soon after this census how many we've got now. Of these, about 17 million are estimated to be anemic, 31% in females, 17% in males. And then there's another 17 million that's got non-anemic iron deficiency, which we now know has got all the symptoms of iron deficiency anemia, even though you're not yet anemic. If we zoom in on the Western Cape, this is a study including both patients from public and private sector. You can see that the overall prevalence of iron deficiency was almost 40%, but in females, almost 57% of supposedly healthy females in the Western Cape have iron deficiency. This is probably the symptoms thereof and are at risk of becoming anemic. The South African Surgical Outcomes Study that was published by Daniela Marcicano here from UCT showed that at the time of arriving for surgery, 47.8% of patients were already anemic. That excludes those who were iron deficient but not yet anemic. And locally, that was associated with a 70% relative increased risk of mortality, 50% increased chance of being admitted to critical care, and longer hospital stays. And we now know from many other studies that if you have preoperative anemia, you quadruple your risk of kidney injury and blood transfusion, you triple your risk of mortality, your cardiac complications, your hospital stay, and you double the risk of infection. And the shocking thing about this, that we did not previously recognize, is that the increased risks do not start when your HP drops below some marker like an HP of 10. We know that even in women, where a normal HP is supposed to be above 12 and in men it's above 13, but even in women, there's a linear increase in risk from the moment that their HP goes below 13. So currently there's a worldwide debate ongoing on whether we have the appropriate normal reference range for females with regards HB, and that females are discriminated against with the lower HB, and that what we thought was normal for females is actually completely abnormal, and in particular has clinical consequences when it comes to surgery. It's not just a single type of surgery. Preoperative anemia is common in all types of surgery. But it's not only the preoperative anemia. Postoperatively, the many patients, and in this particular study by one of the, well, so actually you can see 3 studies by leaders in the field of anesthesia and surgery, up to 90% of patients might have postoperative anemia. And I think this is just showing that there's, if you have pre-op anemia, you've got this much higher risk of needing blood. And blood, we now know, transfusion is an independent predictor of poor outcomes and even independent of anemia. So many people would say, well, the patients just had a worse clinical state, worse anemia, and therefore they had worse outcomes. It turns out that independent of anemia and patient condition, transfusions can lead to a poorer outcome. Right. This is just more of the same, and I think for time's sake, I'm going to go beyond this, but these are just complications at 30 days in patients with and without pre-op anemia, and you can see the red, the orange bars, much higher morbidity of all kinds, including thrombosis, bleeding, sepsis, etc., if you were transfused. And this one just points out again, 30-day mortality and composite morbidity significantly increased with preoperative anemia. I believe global surgery includes all kinds of surgery, including obstetrics and gynecology. So I just thought that it's useful to know that different types of risk factors are now well known to be predictive of a need for blood transfusion. I don't think it comes as a surprise that eclampsia and placenta previa are the ones that give you the greatest risk. But don't underestimate things like general anesthesia. So general anesthesia for a cesarean delivery increases your risk for transfusion fourfold. Right, so what have we told each other? We said that there's many benefits for patient blood management, less complications, lower mortality, better hospital stay, and we're saving blood and the costs related to blood. I just want to say a few words about pregnancy and postpartum hemorrhage, because this is really a topic very close to my heart. And for those who are interested, I've got a number of talks just focused on pregnancy, but today I'll just give you a taster. So if we look at postpartum hemorrhage, estimated to affect 14 million cases around the world. Most of the deaths occur in the low resourced areas, and approximately 120,000 deaths that are potentially preventable in females just from postpartum hemorrhage. 800,000 estimated cases where uterotonics are ineffective, and I've just read an article today from the Netherlands where they've got a fantastic perinatal registry, and they studied 2.3 million pregnancies. 95% of all their pregnancies were included in the study over a 20-year period. And somehow it seems that uterine atonia is increasing and postpartum hemorrhage is increasing over the last 5 to 10 years in particular, and they're still trying to figure out exactly why. One thing they noted was that manual delivery of the placenta at the end led to a 28-fold increased risk for postpartum hemorrhage, but it's still not clear what the other contributing factors are exactly. They estimate that you could avoid 11,000 hysterectomies per year in sub-Saharan Africa alone. And as part of the Sustainable Development Goals, the aim is, of course, to decrease by 2030 the global maternal mortality rate to less than 70 per 100,000 live births. But where are we now in South Africa? Well, we've come a long way. We were closer to 190 and we're down to about 100 in 2018. So we're not quite where we want to be there yet, but we are working there. And I think the Obs and Gynae Society has done fantastic things, including the development of great policies and peripartum algorithms on how to better manage these patients. But they're also working very hard right now on patient blood management guidelines and how to take this forward. Still, if we look at the causes of maternal deaths, infection rates is number one, then hypertensive disorders, but very, very right behind hypertensive disorders, obstetric hemorrhage, still the cause of 17% of all motherly deaths in South Africa. So, what do we know? And this is where I want to just give you a little bit of a taster about effects of not only anemia, note, but iron deficiency on the pregnant mother. So the easy thing to recognize is the lower the patient's HB at the time of giving birth, the closer they are to the cliff of postpartum hemorrhage-related mortality. The lower the HB, the shorter the way to fall off that cliff. The better your HB, the more time to get a transfusion to you or to get you to a transfusion or to an obstetrician or a gynecologist, especially if you're in a rural area. But this is not the only problem. If the mother is iron deficient, her risk of infection is increased. She's got less breast milk. She's got a high risk for postnatal depression and poorer bonding with the baby. And the fatigue and forgetfulness of pregnancy, I really believe, is largely iron deficiency related. We also know the risks of iron deficiency on the baby very well. These things are not a surprise. Increased risk of fetal death, low birth weight, intrauterine growth restriction, preterm birth, and poor bonding with the mother, as mentioned. And note again, what I'm saying is I'm not talking about anemia. Anemia is the end stage of iron deficiency. I'm talking just about simple iron deficiency, even though the patient is not yet anemic. But it's more than this. We now know that if the mother was iron deficient, both premature and mature infants have poor auditory neural maturation with effects, measurable effects on their hearing when measured after birth. Neurocognitive deficits have been recognized in studies around the world for a long time, but this is a local study, Drakenstein Health Study. More than 1,000 children were followed up to the age of 2 years, and if their mothers were anemic during pregnancy, at 2 years of age, these children had lower cognitive scores, lower receptive language scores, and lower expressive language scores. And we now know from other studies around the world, these are mainly American and European, that if you follow these children up, these are children, note very well that their mothers were iron deficient. So they're born iron deficient because they're dependent on the mother for the iron. The fetus is dependent on the mother for its iron. So they are born iron deficient, then they are treated for this iron deficiency. But the effects of the mother's iron deficiency on the fetus's development led to these long-standing consequences, even though you replace the iron in that child after birth. And this is what they found. At 4 to 6 years of age, they still, compared to their peers, at slower perceptual speed, problems with their motor proficiency, language, more fearful, unhappy, weary, tired, and keep close to the mother. But it doesn't stop there. Testing this group of patients in adolescence, they still have slower perceptual speed, poorer spatial memory, attention problems, reading, mathematics, increased chance of repeating a grade, needing tutoring, but also things like risk-taking behavior, anxiety, depression. I just saw a patient this past week that was so anxious that she's already on an anxiolyticum, and all she has is severe iron deficiency. And this can all be reversed. Social problems, delinquent behavior, and even an increased aggression associated with iron deficiency in the womb. It doesn't stop there. Getting to young adulthood, problems with recognition memory, poorer on tests of strategy shifting, and even in adulthood, they were more likely to be single, not to have completed high school or pursue further training and education, feeling more detached, negative emotions, and decreased ratings of emotional health. So in my opinion, we're dealing here with a massive social problem. And this is why patient blood management, which includes the management of vitamin B12 and iron deficiency and simple things like that, has become part of patient blood management in areas like obstetrics, as an example. And what are the things we can do? I'll just give you 3 out of probably 100 things you can do in pregnancy. Well, optimize the mother's iron and hemoglobin, both for the baby and for the mother. During birth, give tranexamic acid. There's 2 publications out in the last 2 months, randomized controlled trials showing that tranexamic acid at the time of birth, the one study looked at vaginal delivery, the other study looked at cesarean section, you almost half the loss of blood and the rate of postpartum hemorrhage. And then postpartum, you restrict blood transfusion. Unless the patient's HP is less than 6, it's hardly ever necessary to give blood to an obstetric patient unless they're bleeding out or actively. If not, and they're stable, you give them iron, and that will sort the problem out in almost all cases. How does all of this affect our blood services? The blood services are active partakers in patient blood management. Both Sandbase and the Western Cape Blood Service work with us because they don't have enough blood. We want to ease the pressure on the blood supply, and we expect the demand to increase anyway. At the moment, both Sandbase and the Western Cape are struggling with meeting the needs. We currently, our blood services provide more than 1 million blood products to about 320,000 patients, and only 1% of our population are blood donors. Blood stock levels are frequently low, and in the time of COVID, we had multiple periods of problems. And note that I'm not against blood. I'm a director on the Western Cape Blood Services Board. So I'm just saying we need to give blood when it is really necessary, because there are people out there that are not getting blood that do really need it. One of the reasons why donor age is now increased to 75 years of age, because we don't have enough donors. Simple as that. What are the economics? We know that, as I mentioned just now, there are many sort of unseen effects of unmanaged iron deficiency on children and their development. But there's also many things related to hospital stay, bed occupation, healthcare budget. If you think of all those complications that were avoided in Australia with patient blood management, what did those complications cost them? There's some studies on the economics of iron deficiency. This one showed that the work productivity lost, especially in females that are iron deficient, are estimated to be up to 9% of some countries' GDP. And from a health economic analysis perspective, it makes sense. The ideal quadrant in terms of health economics is to have something that will save you money and give you better outcomes. You can see on the horizontal axis outcome, on the vertical axis cost. So it's an absolute no-brainer that patient blood management falls in this quadrant. And I can just tell you that the provincial government of the Western Cape is so excited about the savings, the cost savings, tens of millions of rands saved in the province with patient blood management initiatives, that they actually want to force the hospitals to do it because they're seeing the benefits from their high-level quantification. So we have an opportunity here in South Africa to improve our public health in terms of child mortality, maternal mortality, surgical outcomes, blood loss, bleeding related outcomes. And why should we do it? Well, it's simple, good practice. We're not only improving outcomes and saving costs, we're also decreasing pressure on the blood supply. So how do we start? Let's say one of you are now all excited and you like it and you want to be part of it. I think the things that we can focus on first, let's focus on our mothers and babies, optimize their iron and hemoglobins. Surgeons, optimize pre-op anemia. If it's elective surgery, delay it. Get the HP right and learn the techniques of minimizing perioperative blood loss. I remember one of the leaders in the world is the head of anesthesiology in Zurich, in Switzerland, Donat Spahn. And they were telling us about how they're now doing most of their liver transplants blood-free. So I mentioned this to some of the colleagues here at UCT, and it wasn't long after that I got the feedback that they're now doing many of their liver transplants blood-free. So once you know how it works, what you can do, and all the amazing tools that are out there to minimize intraoperative blood loss, it really becomes phenomenal to see the high-level surgery, which sometimes can lead to transfusing the patient's whole blood volume of 5 liters or more, that they can do without giving a single unit of blood. Anemia is never a final diagnosis. You have to look for a cause and treat it. And if I ever get the opportunity again, I can talk a lot more about anemia physiology and diagnosis and treatment. And then when you transfuse, single units as far as you can, and only transfuse if really necessary. And I'm going to, at the end of the talk, say these things again. Don't delay implementing patient blood management because you think it's too complicated and there's too many things you can do. You know, there are low-hanging fruit. We've worked with the anesthesiologists to design an algorithm for diagnosing and treating iron deficiency in the perioperative phase. When your referring doctor calls you with a referral, ask them to check if the patient has got anemia or iron deficiency and to start treating so that by the time they come to you, that patient's anemia is already optimized. If you don't have time to wait, use IV iron. If you have to transfuse, we said give single transfusions. Just an example of what can be done. This is Dr. Rob Wise, anesthesiologist that previously worked at Edendale Hospital. And they used something very simple. They just used a blood accountability form, which I'll show you in a minute. Within 2 years, they saved 4,500 units of blood. They reduced their after-hour levies. And just in this secondary level hospital, they saved 15 million rands in 2 years. And you can see the reductions in expenditure on blood there, 39%. George Hospital, by the way, has cut their blood use by 50%. We've cut our blood use here at Groote Schuur by almost 30%. And they funded 8 medical officer posts with the savings. I think that was great of management to help them with that. And all they did was this. They just used this form. And the doctor had to indicate on this tick list why they're giving blood. On the form, they were reminded what the cost of a unit of blood or platelets or whatever was. And there was someone at the end of the month that collated the data. And if they saw that people were not working within the indications there would be a conversation to see what the reasons were. And very soon, the whole hospital got on board and people started following the protocol. And the rest is history. You can do simple things. Optimize the patient's coagulation by having a little checklist like this one from Stanford University. We often forget that things like that are commonly used in the community, such as garlic, omega-3, some vitamins, vitamin C, E, St. John's wort, can actually lead to increased bleeding. Tranexamic acid is dirt cheap, 25 rands for 500 milligrams vial, which has been shown in many studies to decrease intraoperative bleeding. It's given intraoperatively with over 30 minutes, and then you can give an infusion afterwards over 6 hours. Using intraoperative point of care testing, I know they use a lot of TEGs here at Groote Schuur, can guide your use of appropriate blood product usage. Also, meticulous surgical technique, cell salvage, restrictive blood drawing post-operatively. There are these amazing things like this uterine balloon tamponade that's developed by a company in South Africa, which can you literally just put water in that bag. It fills this, if the uterus is atonic, it fills the bag, compresses the uterus, and as that uterus over time starts to contract, it empties the water in the bag again, but the pressure on the blood vessels stops the bleeding. That's what it looks like. Very simple to insert, and sisters all around the country is using this. If your area is not using it, well, maybe look at it. Then there are things like blood savers that can be used both for vaginal blood loss and for intraoperative cell saving around C-section. I'm not going to go into the detail, just to say that in this study, the patients who actually received autologous blood through the cell saver had a lower baseline HP, lost 43% more blood, and ended with a higher HP than those in the control group. Building a team, well, we need lots of people to take part in our patient blood management program, and we've got people on all these levels involved, and we are open to having anybody that's keen to take part to become part of our team. And our local stakeholders have become the local team, but we connected to an international group of experts, all of whom have visited us on numerous occasions and are on tap to help us with anything we need to have help with. These are literally the leaders in the world on patient blood management, and they're super involved in South Africa. Of course, we teach, we publish, we give lectures and do workshops and annual conferences that we organize here in South Africa. We've had a couple of national conferences. We're planning an Iron Academy. The interns are now doing a course on a module on patient blood management when they rotate through anesthesiology. We've written a chapter for the residents in anesthesiology. There's video recordings, YouTube videos. We've got a WhatsApp group that's open to anyone. I've got some videos on YouTube on iron. There's lots of videos that I've made that you can go and look at. And we've been writing guidelines. These are just two of the recently published ones. We've published on critical care, patient blood management, anesthesiology, patient blood management. We're almost done with gastroenterology, and obstetrics and gynecology is being written. Huge opportunity for research, and I really want to encourage you guys. This is a chance to do lots of nice MEDs, because we just need to start with the easy things. You can literally take any type of operation that you are interested in and say, let's just study preoperative anemia in, let's say, knee replacement, or whatever the case might be. And or post-operative anemia in any type of surgery. Simple things to do, but we really need to understand where are the challenges, which patient groups are currently having problems, and then how do we address it? And then we do studies on what is the cause of the anemia, and I work with different MED students, or I support different supervisors with their MED students to help do things like this. And I know Christella and Matt has got a number of patients on this. So there's a huge opportunity, and I really think there's I always say in research, the goal these days is between disciplines, between hematology and surgery, or surgery and anesthesiology, or whatever the case might be. There's great potential. We've now got tools to monitor our progress. There are these lovely patient blood management bundles where they've developed these what we call measures of how well are you doing. These are years 34 of those 200 and whatever, and you can literally go and self-evaluate how are you doing. So, for example, in April 2018, we scored in Grooteskier 6 out of 34.
Sorry, Prof. Hope you're close to wrapping up in terms
of... I'm at the end almost.
Okay, thank you.
Oh, I see. Okay. Right, and this is just how we monitored and could see that we were making progress as a team. So where do we go from here? We need to overcome the barriers, lack of knowledge. We need to prioritize. We need to take the perception that iron and tranexamic acid and other things are expensive, and also the perception that blood is cheap or free. That's not true, and make this the norm. And I want to ask you, what is the one thing that you want to start doing? Some suggestions, I've already mentioned these. Those are the people that we work with. Thank you very much for your attention, and I look forward to any questions.
Thank you very much for an insightful talk. I mean, you did definitely show the importance of patient blood management, and I would take a couple of questions. Just before I do that, I just wanted to say, yeah, one of the things that, looking at the statistics that you have shared about mentioning that 50% of the blood is being used by surgeons, obviously it shows how it's important to save blood, and also the 3 pillars that you mentioned, the importance of that. However, with that being said, obviously my question would be, what about in low middle income countries? Because one of the pillars was minimize bleeding and blood loss. And we know, as you mentioned, about PPH or postpartum hemorrhage, one of the challenges is in cesarean sections. In rural areas, the challenge is most women lose blood, and that's mostly settings where blood is quite needed. And I can see, obviously, this is a big study. Hopefully, you guys have that in mind. But maybe if you can just say something on that regard. And then lastly, I was also shocked to find out that 90% of postoperative surgery might have anemia. I mean, it might be caused due to some of loss of blood. And then lastly, obviously, I wanted to ask about the part where you mentioned that economically, this can be really, really critical, where about 30% of blood has been saved in George Hospital and Fortiscare. Are you guys also considering like more advocacy or awareness about blood management, patient blood management in some of the areas in here in Cape Town and other provinces where obviously people are not quite well, like clinics or like small hospitals or etc. And then I'll just take also 2 questions once you answer this. I see Prof. Salome and Jared. After Prof. Salome, you can go, and then Jared. Yeah.
Do you want me to comment, or we can take the questions first?
Maybe you can comment, and then we can take questions.
Yeah.
Everybody, please, let's just allow just extra 3 minutes just for the questions to be answered. This was a very insightful topic, and it's critical. Thanks.
Okay, so in brief, I think the key thing is to have champions in every hospital that can drive it. If you don't have a champion, you don't have PBM. It's as simple as that. And fortunately, champions are standing up everywhere. In Mitchell's Plain recently, somebody has started and written a fantastic protocol there for patient blood management. And so we're working with anybody that is keen, and we've got about 140 people on our WhatsApp group around the country that we send out guidelines and suggestions and ideas, and we share our expertise. And it's very great. Many of the department heads around the country in these different types of specialties are involved. So yeah, huge things are happening, and education is key. And that's why I give talks like this almost every week to some specialty. And it's actually the people in the specialties that are doing the good work and are doing the savings. I'm just doing the teaching, but the people, you guys are doing it. So exciting to see.
Excellent. Thanks. Prof. Salome, you can ask your question, and then after that, Jared.
Thank you so much for the opportunity. And I really just want to say thank you to Prof. Louw for joining us today. It's just been incredible listening to you, and just, I think, a new opportunity for us as global surgery to also, collaborate and partner. A number of the people that are here in the call, a lot of our fellows are not even in South Africa, they're in other African countries. And so this kind of talk reaches far wider. And so I just really want to thank you, and to thank Christella for organizing as well. But as a division, we're really grateful, and we'll look forward to more opportunities like this so we can share in the advocacy, education, and of course look for research collaboration opportunities. Thanks.
Thank you, Prof.
Great.
Swime. And I think you guys are ideally seated and suited to take the lead. I see myself as someone to support. And you guys are really the leaders. You are at the coal face, and I want to be there as a help. So yes, I'm available if you need me.
Excellent. Great. Just before, sorry, Prof. Salom, do you want to continue?
No, thank
Okay.
you very much.
Okay, I was just saying, just before we take more questions, I just want to thank you, Professor. This was really insightful, like Prof. Salom mentioned. Also, it just makes more sense also in terms of global surgery. I just want to close the meeting now, say thank you everyone for attending, but please do stay on for more questions, and after that we'll just say our goodbyes. Thank you everyone. Thank you Amy, thank you Christella, and thank you Regan, also one of the speakers. Thank you. Okay, we'll go ahead. Jared, you can go ahead.
Okay, perfect. Thank you. First of all, thank you, Prof. That was a really interesting talk that you presented. And then it's a bit of a slightly long-winded question, but I'll be brief. I'm an MSc fellow at the moment with global surgery, but I'm also currently working in Berlin with a menstrual tracking women's health app. And I'm doing a lot of their pre-research at the moment, looking to move into managing medical disorders. And I actually presented something last week about anemia in women, anemia in pregnancy, and iron deficiency. And one of the studies there's obviously limited research in the space of apps and mobile health, but one study did find that they had a 30% decrease in the need to present to hospital for people who had known bleeding conditions that looked specifically at adolescents with heavy menstrual bleeding. And I just wonder, I suppose my question is more in terms of the big issues with pre-hospital care, how much we're also looking into technology as a solution. And like this study, for instance, found that just helping people to track and giving them the information and education in their hand, it was just as effective as giving people picture charts like we used to do, or we do in under-resourced spaces. And I don't know, I think I just get very excited with the potential for technology, especially in underserved communities, which feeds into global surgery as well. And the opportunity to try and address these pre-hospital issues and managing and making sure people are taking treatment and logging in. And I just think there's a really interesting potential for technology to form part of this pre-hospital space. So it's sort of an open question of how much we've looked into that or possible solutions within that space, you know.
Jared, thank you very much and congratulations on what you're doing. And I can't agree with you more. And we are looking at technological solutions, which so far has been mainly aimed at education. But you're right, there's a phenomenal opportunity for using technology and apps in this space. I mean, imagine what they say, at least a third of young women are having menorrhagia, hey? 1 out of 3. So, and they often don't know it because their mother and their sister also had the same genetic predisposition to that amount of blood loss, and they don't recognize it as abnormal. Whereas it ends up with many of them presenting to us with their HBs of 2 or 3, as you probably have seen. So I'm keen to listen, to hear more of this, and maybe offline you can make contact with me, because there's some very interesting work done by Toby Richards' group in the UK, is now in Australia, with some very simplified 5-question things that can help detect menorrhagia in a very accurate fashion. And I'd be very keen to see what you are using and what sort of tools you are using for this, because this is what we need exactly. And it's going to be better than just websites and stuff like that. An app is the way to go, I think, in the modern time. So well done.
Great. Thank you. Just in the interest of time, I'll just only take Maureen, and then if you have more comments or questions, you can just put it on the chat, and then we'll share it with Professor. For now, we'll just take Maureen, and then after that, we'll fully close. Maureen, you can go ahead.
All right, thank you so much. Thank you so much, Prof. Louw. My name is Maureen from the Department of Biomedical Engineering. I'm a biomedical engineer by profession. And I'm also working on 2 biomedical engineering innovations targeting postpartum hemorrhage. One of them is a device that's for real-time assessment of blood loss, and all these are based in Uganda. And the other one is a device that mimics the bimanual compression. That's after when someone has gotten postpartum hemorrhage. And I was just keen on looking at how engineering or how medical devices can come in to the patient blood management tool and assessment. And I'm coming from Uganda. One of the things that I know is very many women in the rural areas almost do not go for prenatal care. They literally they don't go to the hospitals. And so many times it's when they come to the hospitals that we identify, okay, there is this, you're likely to get PPH. But I'm just looking at how we can attend to patient blood management in the stages prior to someone giving birth.
Yes.
And how we can use engineering to solve that. Thank you so much.
Maureen, it makes me very excited to hear that. I've been working with biomedical engineering. I actually have a master's student as well from with Sudesh. So yes, you are so on the you're on the number there, because yesterday I had an hour-long conversation with the CEO of an engineering company here in Stellenbosch, the company that makes this. The device that I just showed on, to stop the bleeding, and they're also working, and we've taught them about patient blood management, but without, even before we taught them about the concept, doctors were using their underwater drains for thoracic drainage, for instance, to collect blood and reinfuse it to the patient. And I think that's one of the important areas. And they're now developing a digital drain which can measure loss and losses. So we had a long conversation about what can be done in the peripartum period to monitor and measure blood losses and stop and decrease it. So certainly a person to also have a conversation with if you're ever interested, but you are working in the perfect place and field, and I really look forward, and please keep in touch, even if you just want to share with me your successes or your challenges, because I really am interested to see what you are able to do with this. This is important. And I had a PhD student from Ghana that worked on iron deficiency, up to 90% of that part of Africa. Now you're on the other side, on the eastern side, but on the western side, up to 90% of women are iron deficient from our studies. She's a dietitian, and it's a massive need in Africa that we need to address.
Great. Thank you. Do you want to say something quickly before, Maureen, or are you happy?
I'm happy. Thank you.
Yeah. Great.
Thank you.
Thank you, everyone. And hopefully you can connect Maureen with Prof, because listening to what you mentioned, what you're doing is quite critical and it's important based on what they're doing. And then thank you, everyone. Have a lovely afternoon and see you for the next academic meeting.
Thanks, everybody. Appreciate the time.
Thanks, everyone. Thanks, Prof. Louw.
Thanks, Regan.
Thank you.